Good afternoon, everyone. My name is Andrew Bluestein. I'm Vice Chairman of Garfunkel Wild. I want to thank everyone for joining us for practical aspects for ASC reopening. I hope everyone is sane and healthy. If you had asked me 2 months ago, would in fact we be having a topic about how to reopen ASCs, I think you would have thought that I had lost my sanity. But here we are. And things are really changing, and we're hopefully coming out of this period that we've been in, which has not been fun. And as states are reopening, and New York, New Jersey, and Connecticut, which is our primary markets, have issued guidance, we quickly got together this panel to try to help you consider all the issues. And I really want to thank everyone who has come together. But if you're listening to this, whether wherever you are or for our YouTube channel, and you're in a state other than the three I mentioned, the guidance that's coming out throughout the country is very similar. So I think the vast majority of what we're talking about will have utility no matter where we are. So our speakers have gotten together to help us help all of you with the educational challenge of how do we reopen something that we never thought we'd ever close. And they all have busy lives, and they took some time to help us out here. So let me introduce them. We have Teresa Chason, who's the Senior Director of Clinical Support, Compliance, and Risk Management from Physicians Endoscopy. She will be talking about infection. Prevention, not getting an infection. She will then hand the baton off to Monica Ziegler, who will give us the administrator's perspective. Monica is the administrator of Manhattan Ambulatory Surgery Center, which is a center in Manhattan that is multi-specialty. Then my partner, Roy Breitenbach, will take over to give us some of the HR aspects that are involved in closing, and there's more than you would even imagine. And then we're very happy to have Nicholas Melchiori and Dr. Andrew Brooks from Accurate Diagnostic and Rutgers RUCDR, which formed a joint venture, and they'll be able to speak to how testing overlays all of this. At the end, we're going to try to have a panel discussion. We're hoping to do it for about 10, 15 minutes. As we're talking, feel free to put questions. At the end of this, all the registrants are going to get slides, have the slide deck plus a recording, and it'll also have everyone's email. I know a lot of you are sitting around a table, or some of you have told me you're sitting around a table. Hopefully you're socially distanced away, but it'll only go to the person who registered. But you can always go to our YouTube channel and pull it off from there. So we've got a lot to try to do in a short period of time. We're scheduled to go till 5:15. I know that's kind of a strange time, but we added 15 minutes because there's a lot of material to cover. So with that, oh, I went too far. Okay. So when I was putting together my notes, I realized there's a good Aretha Franklin song, which kind of spells out, we went one too far, which spells out everything that I think we're talking about. And that is, we're trying to bake in the regulatory environment that is changing and confusing. And for all of you who keep calling, asking us to make sense of it, we're doing the best we can. How do we deal with employees? Both from a health perspective and a legal perspective, but it's not just employees, it's really all staff, independent contractors, vendors. How do we get everyone on the same page? And of course, the patients need to feel protected, and how do we protect them? And this is constantly changing. I know that you're going to send in comments. You think the speaker said X, it should be Y. We're all in a community, and this is constantly changing, and hopefully nothing changes in terms of infection rates, but if things start to go up, obviously the regulatory guidance is going to change because we're all in a big community. But as everyone has been saying, testing is really crucial here. And so we'll be touching that as well. So with respect as our theme, I will turn it over to Teresa to take us through her presentation. Teresa, can you now, right, there you go.
Hey, sorry about that. Good afternoon, Andrew, and thank you for that introduction. Introducing myself again, this is Teresa Chason. I'm the Senior Clinical Director for Physicians Endoscopy, overseeing the clinical operations for 9 endoscopy centers in New York and New Jersey. I'd like to take this opportunity to thank Garfunkel Wild for including me in this important discussion. During my presentation, I will be reviewing key infection control measures and discussing all the new policies and protocols that are now required during this COVID pandemic. Formulating a reopening plan is a complicated process and requires significant effort. My colleagues in IAPE have been working for weeks on reopening protocols, and I'm pleased to be able to share all that work with you today. I've included over 40 slides in this webinar, but due to time constraints, I will not be reviewing all in detail. Please feel free to use any slide as a reference and edit for your specific needs at your ambulatory surgery center. Thank you. Sorry guys, the slide, there we go. So I would like to start this presentation by sharing the global data of those affected by COVID-19. As of May 17th, we have lost over 300,000 individuals to this virus worldwide. Of those deaths, the United States has taken a significant hit during this COVID pandemic, which is why containment of this virus should be the utmost priority when establishing your reopening protocols. As we can see from this New York Times COVID tracker, the impact of COVID-19 in the U.S. is significant. We have lost almost 90,000 individuals in the United States in just over 3 months. When we compare our numbers with the rest of the world, it highlights the profound effect that COVID has had on us. We have lost almost 3 times as many patients as any other country. When we look regionally, the numbers in New York State and especially New York City are alarmingly high. New York City is without a doubt the global hotspot. We have lost over 20,000 patients in New York City alone and over 28 in New York State. We have had more deaths in New York State than all of Spain or France. It is important to understand these numbers for the reopening of our New York centers, as well as our neighboring centers in New Jersey and Connecticut, to reinforce strict IC measures to support the continued downward trend of the virus and prevent a much feared second wave. Just like today, Americans were desperate to emerge from quarantine during the 1918 Spanish flu pandemic. But a second serious wave of the virus was projected, and many cities and leaders ignored the warnings. The second wave was the most deadly, with 50 million deaths worldwide. We should learn from our past mistakes and reopen our centers and communities using facts and proven data to reopen responsibly. Before we review reopening protocols and infection control measures, I would like to take a moment to mention the serious mental health impact this pandemic has had on our healthcare community. PTSD is real in healthcare, and now it is more important than ever to ensure we are openly having these conversations. We can no longer accept that it is just part of the job, and we need to ensure those affected are encouraged to seek support. I've attached a hotline number specific for healthcare workers, and I did research this support line, and I can endorse its use. We should also be aware of those practitioners who are returning from the COVID ICU units to our centers. They may have a heightened level of anxiety, and we should be prepared for their questions and need for extra reassurance of the protocols that are in place to perform safe elective procedures during this time. So reopening our ASCs, how to step through the many guidelines and recommendations to provide the safest environment possible for our patients, staff, and physicians. So preparation is the key to a successful reopening. We need to ensure we appropriately screen and prepare all our patients. We need to educate and prepare our staff and physicians, as well as making adjustment to the physical layout of our centers. Let's now review the steps required to reopening your center. So pre-screening patients. Pre-screening patients is a major contributing factor to the success of your reopening plan, as well as a department health mandate in many states. These calls should screen, educate, and prepare the patient for this new COVID environment. All patients need to be screened and cleared for any COVID symptoms or exposure to COVID-positive individuals, both at the initial telehealth appointment, followed by all subsequent phone screenings prior to procedure day. We will review the new Department of Health testing mandates in certain states later in this presentation. So realistic goals are the pre-calls and pre-screening of the patient. During any patient interaction, you should work towards alleviating the patient's anxiety about having a procedure in this pandemic environment. We recommend creating a center-specific script that explains the extensive precautions and guidelines that you have employed to provide the safest environment possible for all your patients and staff. A sample patient script is attached on the next slide, confirming the appointment time and date with the patient. This is now more important than ever, as we need to ensure patients are comfortable having their procedure in this new uncharted territory. If the patient does cancel the procedure during the pre-call, we recommend tracking these cancellations to evaluate if more PR is required or to review the possibility that maybe you reopened too early in this pandemic. And the most important aspect of the pre-call, pre-screening for the symptoms or exposure. I do have a sample screening tool also attached later in this presentation. So these next two slides are samples of a patient information tool patient script that I mentioned earlier. The first three components listed here include planning for the procedure, arrival, and the registration process. We need to ensure the patient understands the new protocols of no escorts in the facility, the expectation of screening at the facility door, including the taking of their temperatures, performing hand hygiene, and the placement of a surgical mask, as well as preparing them for the possibility of an empty waiting room. We also need to educate the patient in depth as to what to expect before, during, and after the procedure. We have always provided pre-op education to our patients in the past, but in these unsettling times, this pre-education is crucial. Reviewing the social distance policies, the optics of all staff wearing masks, the limited or potentially no visitors in PACU, as well as a review of what the patient could expect to see in the procedure room as all the staff is in full PPE. The time spent on these pre-procedure preparations that I mentioned earlier will be multifaceted. It will reduce the patient's throughput, as they should have the majority of their questions answered, but as we know, we may still expect questions and the need for reassurance on the day of procedure. I recommend utilizing the same script for all your communications with all your patients to ensure a consistent message is given. As I mentioned, here's a sample screening tool. This tool is for national use and must be edited for your specific state. Regionally, we have had significant testing mandates. On May 19th, the New York Department of Health declared all ASC elective procedures will require COVID pre-testing for all patients within 72 hours. And the New Jersey Department of Health requires testing within 96 hours of the procedure. Once the patient has been appropriately screened, educated, and cleared for the procedure, we can now plan for the day of admission. So day of the procedure. Your patient arrives at your facility. We recommend a trained staff member to greet the patient at the center entrance vestibule if available. Take the patient's temperature and verbally review COVID screening tools again. Once they're cleared of no fever and no symptoms, you can proceed with arrival protocols. Request the individual perform hand hygiene and place a surgical mask on prior to entering the center. Have small Ziploc bags available for any patient who arrives with their own mask, and request they store this mask and wear the new mask provided. Waiting and registration area. Again, prepare your patients for a possible empty waiting room. Some key items to be aware at registration. Reorganize the furniture to ensure social distancing is maintained with ample signage to remind all of the required 6 feet of distancing. Ensure your registration staff understand the importance of disinfecting the patient registration area after every patient. I would recommend a documented in-service to confirm that your front desk staff, which are your non-clinical staff, understand the importance of contact time for your center-approved disinfectants. As a quick refresher, contact time means the amount of time the product must be in direct contact with the surface. So it must be wet for that set time to be effective in killing the virus. Failure to follow the manufacturer's set contact time could pose a potential area of transmission from an asymptomatic patient to your next patient. So here I'm happy to share a picture from my first successful reopening of a center. Last Saturday, 5/16, at an endoscopy center in Lower Manhattan. This center saw a 100% show rate, 0 cancellations, and their schedule moved exactly as planned. Their success, in my opinion, was a product of presenting consistent patient messaging as previously described, a comprehensive staff training pre-opening, and performing mock patients prior to the reopening. Some lessons learned from this team they shared with me: give yourself enough time for PPE changes, especially in the early days, and designate a PPE monitor to support compliance and alert staff to any breaches. In terms of the actual procedure rooms themselves, declutter the room as much as possible to maximize cleaning efficiency. Place signage on the door to alert all that a procedure is in progress. And the CDC has recommended reviewing your air exchange rates to determine minimum room turnaround time. Here is a simplistic table straight from the CDC website to review airborne contaminant removal, listing the time required to provide either a 99 or 99.9% air contaminant removal. For example, if your current procedure room has an air exchange rate of 10, it would require 28 minutes for 99% of the airborne contaminants to be removed. As I mentioned before, I work primarily in endoscopy, and there have been multiple articles written on the aerosol generating nature of endoscopy. And as such, all members of the endoscopy team should wear N95 respirators or an equivalent filtration rate mask when they are in the procedure rooms. And here I've provided a link for N95 fit testing. This video goes right to the OSHA and has multiple resources, both for training and where to get fit tested. Here is a flow chart that I would recommend you edit for your center on patient movement throughout the center. I know the font's a little small, I apologize. This highlights the number of interactions that occur with the patient throughout the center, and the need to be acutely aware of social distancing and the time frame that now most likely will be extended, and you need to set up these protocols and expectations in advance. So this clear diagram could be used for all in your reopening plan. In this slide here, we did a review of the additional time required that may and probably will be a factor during this COVID pandemic. We have reviewed data from our centers throughout the country that were able to open early in the pandemic. And we found clear data points to share the possible steps to reduce these times. For example, the admission process we found had been increased due to the patients being unable to clearly hear the visual instructions due to the staff wearing surgical masks. Possible solutions would be utilizing visual cues and digital platforms to minimize the verbal communication as much as possible. And here again, we show the benefits of a comprehensive pre-patient education on the new protocols that will help the patient throughput on the day of surgery. So here, I'm going to stop, and I have the next 6 slides are very comprehensive material on all COVID transmission and EPA products that will kill COVID, and how to make sure that you are using EPA products. I do want to highlight some data from here. More than 40% of all infections may be transmitted prior to the patient becoming symptomatic. So that's significant. Another point is the risk of infection transmission is highest in the immediate vicinity of a COVID patient. cough-generating aerosol clouds can extend 1 to 2 meters, which is the 6 feet. It can be deposited on surfaces where it can remain for up to 72 hours, but that has not been confirmed. And the last, so here is staff expectations, and I have 15 slides here as well, which is a staff training guide that I recommend you utilize on your staff training day. It has links to proper hand washing, donning and doffing PPE. As well, in the end, there's a comprehensive check-off training guide that I recommend you document all the training that you provided before you reopen the doors. So with that, I think my time is up. I hope you found this very helpful and informative. Thank you very much, and I'm going to turn it over to Monica.
Monica, I think you have to take your phone off of mute.
I did. I told you nobody ever has a problem hearing me. So,
go for it.
I'm Monica. Hi. Thank you, Andrew, for having me. And I am the administrator at the Manhattan Surgery Center, and I've been an ASC administrator since about 2005. And I've been a nurse probably since before many of the people listening were born. So, but I can say this is new to my realm of experience with COVID-19. As a staff person, I've often thought about the people that are above me and my bosses, and I always thought that they probably have really glamorous lives, and I wondered what they do at night. Like they're probably out eating at fancy restaurants or going to shows or musicals, whatever. Well, I thought I would clear the air for any of my staff that might be wondering about the nightlife of an ASC administrator, especially during the COVID pandemic. There are many, many, many questions and many, many sleepless nights. And my first question is, how will I protect my patients and staff and physicians? And which patients take priority as we open to elective cases again? What if we run out of masks or gowns or circuits? How many patients can we see in a day before we overflow the waiting room? What's the PPE burn rate, and who will calculate this daily? As I continue to lay awake at night, I think one of the resources that I've often turned to is Atul Gawande, the Checklist Manifesto. And Atul says, our great struggle in medicine these days is not just with ignorance and uncertainty, it is also with complexity. How much you have to make sure you have in your head and think about. And there are 1,000 ways that things can go wrong. So what we did at the center was we created a critical pathway to operational reopening post-COVID-19. And in our critical pathway, the first part is the risk assessment, which is mandated by the accrediting agencies. And the next part is the critical pathway that actually designs our reopening. So we also, as Teresa included, there's a very important step of assessment of staff, vendors, and patients, all of it listed in detail. The PPE, how much do we need and where do we keep it and what kind do we need? Prioritization of cases, clinical protocols for patient care, clinical mandates and processes, and all listed in detail so that there's no confusion for the staff when they go to read this. Phase 1, scheduling of surgery, Teresa touched on it. Phase 2, the day of surgery. Phase 3, cleaning protocols, and be specific, because what you think you need to do, you really need to go to the CDC website and look up all the details. And a continuous phase is quality measures, which we have always kept in place. And of course, we listed our references. So as I lay awake, I came up with the screening protocol, or I listed the screening protocol in my head, which was pretty easy because the CDC spells it out for us, as does the Department of Health. And I won't reiterate it because I think Teresa touched on it well. The second thing is all patients must be tested for COVID via nasal swab or other means, not more than 72 hours before surgery. If they have a positive result, it will require a postponement in their procedure. And that's in accordance with the Department of Health as of 2 days ago and their April 29th ruling. No vendors unless absolutely necessary. We do love some of them, but this is not the time for them to come and visit. We're prepared to do Zoom chats in the room if we need to, if we've got something special going on. Next night, I lay awake thinking, how do I maintain stock in the era of surge demand? How many PPEs do we need to have on hand? How often should I order them? DOH on May 19th said you need a 7-day supply. However, that's not enough for my head. I need a little bit more than a 7-day supply, especially in time of back orders and allocations. Who will monitor all of this? How do we prevent theft? And believe me, you're going to have theft of these PPEs. May we reuse masks? Which supplier is best? And my favorite, mirror, mirror on the wall, who's the best negotiator of them all? Well, I think I'm the best negotiator, but you may have a better negotiator than you. But it's very important that you still negotiate pricing, because the prices are going exorbitant places, and you need to try to maintain that. Your revenue stream has just been cut off for 2.5 months. PPEs. The N95s in our multi-specialty center are being provided for anesthesia and surgeons that are working above the shoulder level of patients. They also should wear a surgical mask over their N95 to prevent soiling of the N95 so they're not throwing it away constantly. Patients will be asked to reapply their mask in the PACU, and we too are giving them when they walk into the center, they get one, and when they get back to recovery, they need to put it back on. Gowns should be worn in the OR by all staff in the room and properly discarded at the end of each case. No one should leave the OR with a gown on. You know how many times OR staff go walking down the hall because it's freezing cold there and their gowns are flapping. No more. PACU staff may wear gowns when caring for patients that have had upper airway surgery. And any OR tech who sets up a room will need to stay in the room, no leaving the room. All good practice. There should be minimal breaking of scrub during a case unless it is the only time for a lunch break or it's an emergency. Cut down on your misuse of PPEs. The materials manager will be responsible for maintaining the PPE burn worksheet, and there's actually a calculator on the CDC website that you can download to your phone that calculates your PPE burn rate. And our OR manager, who we call the policeman now, will be responsible for maintaining lock and key over the PPE materials and handing it out to the employees as needed. While we are looking at all of these things, don't forget to look at your buildings. How often are they cleaning the building? Is the front desk person wearing a mask? Are the elevators cleaned, and how often? Public restrooms, are the sinks working, and are the soap dispensers filled? May we limit patients to the front elevators, which is something that we did. And just a fun fact about our building that I discovered just doing this PowerPoint presentation, our building was built in 1930 by Warner Brothers, and it was known as the Movie Lab. What a neat thing. Now, the tough question, prioritization of cases. How will we handle all the patients and keep all the physicians happy and all persons safe? Maybe we should propose multiple options for the board to vote on, choosing the ideal one for the center. Like maybe option 1 could be limit every provider to 50% of their total average caseload. That rewards frequent users and efficient surgeons. Option 2, limit only to the owners the first few weeks. Oh no, that might not be very good. We do love our guest surgeons and we don't want to lose them. It's not a time to lose that. Option 3, there's a MENT scoring system, which is medically necessary, time-sensitive procedures. It's a scoring system to ethically and efficiently manage resource scarcity and provider risk. It's a very well done tool, but it is very complicated. Nah, probably not good for us. Might be best for hospitals. And option 4, create our own methodology. And that's kind of what we went with. We recognize that to open the doors to all cases at the onset of reopening would cause an overwhelming influx of cases, more than the center could handle. and more than would allow us to maintain a safe distance from patients and others. So we decided that we will open with a stage entry, utilizing the process below. All patients will be ranked by acuity, which factors in the patient's acuity and the physician performing the procedure. Hang on, my computer screen just went funny. Oops. Based on the score of each patient, the center will seek to operate no more than 50% of our normal caseload in the first 2 weeks. We've got to practice and get it right, make sure we're doing the right thing. Third and fourth week, the center will allow 65% of normal caseload. And the fifth and sixth week, we will remain at 75% capacity, all to minimize exposure. During this time, the task force will meet and will assure that we have all the necessary supplies and staff to allow expanded hours to accommodate all cases at any given time. The limit under normal operating times, as stated, 50, 65, 75 caseload, with growth under expanded hours to full capacity after 6 weeks, if supplies and staffing allow flexibility. Otherwise, safe distancing, adequate PPE, and staffing will be the moderators to increasing the load. Just to let you know, each of our physicians are going to have to measure up quality, cost efficiency, and OR utilization. Quality has always been there. Cost efficiency, this is a time when we're going to look at case costing averages, which requires that a physician's case cost remains within 20% of the average cost of the same procedure performed by other center physicians, and OR utilization time using the same metric. As you can see, this is our patient acuity score. It's a scale of 1 to 5, and for each score that the patient has, we will add 1 point to each patient score to be performed by owner physicians. The surgeons must document indications for surgery on the scheduling sheet, and we will have representatives from each specialty that will review the acuities assigned as needed, just to keep it all clean. Patients will be added to the schedule in a 3-phase entry system. Week 1 and 2, score 4 or greater. 3 and 4, 3 or greater. 5 and 6 will open to all patients. And as you can see, physician owners will maintain their block time. Guest physicians will request hours. Those additional time will be first allocated to all physicians with a backlog of patients with a score of 4 or greater, and then a score of 3 or greater, and so forth. Just to kind of summarize here, we added our new clinical protocols and quality measures, and the things that we looked at here: new patient information brochure that includes what to expect and what to know prior to surgery. Discharge teaching is now being completed on the pre-op phone call, and in the process at the moment is an online registration program. The director of nursing will be responsible for monitoring the number of positive patients, compliance with PPE protocols, room turnovers, PPE burn rates. She is our quality assurance girl. Physician offices, we're going to require that they send us scheduling paperwork 4 days in advance unless it's an add-on. We're scheduling lunches for staff to limit the number of people in the lounge. The defined cleaning protocols, they must include before the procedure, between the procedure, and after the procedure, and we have cleaning log sheets now that we've never had before. And the OR director, he will monitor the surgeon performance within the 20% range of standard for time and cost, and he's also responsible for monitoring the drug availability because it's all going on back order and allocation. The administrator, that's me. I'm responsible for looking over all of these things, but I have a great team to help me with it. So I get to go to sleep now. Just want to let you know, find a way to take care of yourself through all of this. Good luck and sweet dreams. Next.
Excellent.
Go to Roy.
Excellent. Yeah, okay. Roy, before you take off, just for the people who keep asking, we're going to be sending all the slides to everyone at the end. So don't worry, it'll come with the thank you note for registering. And it'll also have the audio. Roy, take it away.
Okay, thank you. My name is Roy Breitenbach. I'm one of Andrew's partners at Garfunkel Wild, and I help ASCs and other providers resolve their business and employment disputes. So I'm going to bring everybody down by talking about some of the legal implications and things you need to do or be concerned about now that you're going to be reopening after lockdown. And what I'm doing, the way I've designed this presentation is in a series of questions that I think are all in the back of your mind. And I'll touch some of the topics that were discussed before, but it'll be from a legal perspective. So first slide is, what do you need from a legal standpoint? Well, you absolutely need to have the personal protective equipment from a legal standpoint as well as from an operational standpoint. Our general recommendation on all of this is to follow the CDC guidelines as much as possible. And the reason why we're suggesting this is very simple, is that if there's ever going to be a lawsuit or a claim about improper exposure, it is best to say that you've been following the CDC guidelines. So when all else is you're unsure about, always try to follow the CDC guidelines to protect this, to deal with this issue. And that would mean obviously cloth face covering for patients and visitors, social distancing protocol and signage. Make sure you have all of that. As the people before me have talked about, a cleaning and sanitation protocol, and potentially a separate COVID-19 positive zone in waiting rooms and things like that. These are all things that if you follow these and the other CDC guidelines, you're going to be able to defend yourself later on if you have any type of improper exposure. What's also important to remember is before you reopen, you got to make sure you have sufficient workforce availability. Your workers out there are going to be nervous about coming back. They're going to be eager to come back and make money and resume their careers, but they're also going to be worried. And so before you open, you have to make sure that you're going to have the sufficient workforce availability. That's really a liability control issue that you should be concerned about. And as has been alluded before, it's not just what you're doing in your particular space, but also what your landlord is doing in terms of cleaning and sanitation and these other things. Because you want to make sure that you're in a building and in a space in which your patients, your employees, your staff are protected as much as possible. So the next question is, can you refuse to treat the COVID-19 positive patient? And that's somewhat less of an issue because, as was explained before, there are mandatory requirements for testing before an ASC does any type of procedure on a patient, and that's been discussed before. It's important to remember, though, that under ordinary circumstances, you would not be able to refuse to treat a patient because of a medical condition they may have, such as COVID-19. There's a lot of case law that says that you can't discriminate against somebody because they may have a medical condition, and therefore, in most circumstances, an outright refusal will be improper. But given these unique set of circumstances and the fact that COVID-19 poses such a direct threat to the community, to your ASC, to the patients and the visitors, you can refuse or you can postpone stuff, particularly if it's clinically indicated, if a patient is positive, test positive for COVID-19. But it's important to remember always that this is a unique circumstance, and when we resume regular operations, just because somebody has an unrelated medical condition, you will not be able to refuse to treat them unless there's a clinical reason why you shouldn't. So that's an important point. Okay. The second point is what's the first employee decision you need to make from a legal standpoint? When you're coming back into opening up, the first question you have to come across is, how are you going to handle the Families First Coronavirus Relief Act? This is the statute that created two sets of benefits for businesses with under 500 employees. Number one, it had federal paid sick leave, and number two, federal paid extended family and medical leave. Both of those benefits are optional to employees who are healthcare providers. And because all of you are ambulatory surgery centers, everybody who works for that ambulatory surgery center is considered by the government to be a healthcare provider. So the decision you have to make before you resume operations is, are you going to provide these benefits to your staff, or are you not going to provide these benefits to your staff? This is the most important question to ask. If you decide to provide the benefits to your staff, then you're going to get tax credits that are designed to pay for the benefits you pay out to the staff. And if you decide to pay these benefits, the amount that you pay in these benefits are not part of any PPP loan forgiveness because you're getting the tax credits. If you decide not to pay these benefits, you're not going to get the tax credits. So it's up to you as a business to decide what you want to do. It is important that you do this at the beginning, because pretty quickly you're going to be confronted with situations regarding employees wanting to take leaves and things like that, in which you're going to be confronted with having to deal with it. So the first thing you should decide is whether or not you're going to provide these benefits. Okay, and you can't provide them for some employees or not others. That's going to get you into an argument about discrimination. So you have to make the decision across the board right at the start of reopening. Next question. Can you require employees with COVID-19 symptoms to stay home? Absolutely. The Equal Employment Opportunity Commission has said that because COVID-19 positive individuals pose a direct threat to fellow employees and patients, you can direct COVID positive patients to stay home. Of course, when you do send them home, that employee would be entitled to whatever sick time benefits they would be entitled to under your policy or under the law. And that's why that's why I said that the first question you must answer is whether or not you're going to provide the federal benefits, paid sick leave, paid family and medical leave, because one of the benefits, if you decide to provide paid sick leave, sending an employee sent home for COVID-19 would be entitled to would be federal paid sick leave benefits. So, absolutely, if there's a positive test, you should send them home. Okay, you can require a medical note to establish fitness to return to work. We recommend that in all cases you do that. You have some documentation that the employee is fit to return to work after being exposed on COVID, or being COVID positive, I should say. And it's important for returning employees to follow CDC guidelines regarding returning workers exposed. Again, for liability purposes, it's vitally important that you try to follow CDC guidelines as much as possible. The next question is, how do you handle fearful employees? You can handle fearful employees, but before we do that, one of the things I want to talk about is the issue of testing. The issue of testing is an important issue. You are entitled to test employees. Temperature tests of everybody walking in is perfectly permissible. If you're going to do that, the most important thing to remember is you need to have a sign or some type of notice provided to your employees that says that the information that's being taken during this temperature test is going to be provided to the employer. That gets you around any HIPAA issues with regard to taking tests. And any tests that you do perform, any tests of employees, any medical information you get from employees as a result of that test, whether it's temperature results, whether it's positive COVID-19 tests, any of the documentation regarding those tests, if you choose to keep that material, you must keep it a file that is entirely separate from your standard personnel file. And that file in which that information is collected has to be kept confidential. That's a requirement of the Americans with Disabilities Act. So, we're recommending that you do testing of your employees when they come in, temperature testing, doing screening questions about symptoms, potentially performing a COVID-19 test. all stuff you should actively consider doing, comply with all of the various CDC and health department guidelines. But it's important to remember that you let your employees know when you're doing the testing that the information is going to be shared with the employer, and you have to keep whatever the results are separate from the regular personnel file and keep those results in a confidential manner. So now another very important question is, how do you handle fearful employees? This is going to be a big issue. There are going to be employees in the ASC who are going to be afraid to come to work. They're just going to be afraid for a variety of different reasons, and you're going to have to deal with it. And it's important when you deal with this that you deal with it in a legally compliant way to not run afoul of violations of the Americans with Disabilities Act or related statutes. So the first question you need to ask in that circumstance is there an underlying medical or psychiatric condition supporting this fear? For example, do they have a comorbidity that makes them particularly susceptible to COVID-19 complications? Do they have severe diabetes? Do they have COPD? Do they have some other underlying medical condition that makes it really serious or potentially even life-threatening if they contract COVID-19? If the answer is yes, you have to consider whether or not that underlying medical condition will qualify for a disability under federal and state disability discrimination laws. And these conditions, diabetes, COPD, similar conditions, are in most cases going to be considered to be a disability. So now you are dealing with an employee who has a disability. And under the ADA and state and local anti-discrimination laws, once you have an employee with a disability, you have an obligation to enter into an interactive process with them to determine whether or not they need a reasonable accommodation. So if an employee has one of these underlying medical conditions that makes them specifically susceptible to complications from COVID-19, a reasonable accommodation that you may have to provide that employee is to allow that employee to telework, right? If they can telework, that's certainly a reasonable accommodation, and a lot of the commentators are saying that. If the employee's position, if the essential functions of that employee's job do not permit him or her to telework, then you have to consider whether or not there's another reasonable accommodation, such as leave or other things that will accommodate that employee with a disability. You also have to remember to consider psychiatric issues as well. An employee may have a serious psychiatric condition, a serious anxiety condition that might qualify as a disability that really that would require them to get a reasonable accommodation, such as permitting them to telework or to give them unpaid leave to get them over the COVID-19. But again, the first question you need to ask about fearful employees is whether there's such an underlying condition. Okay? If there is no medical or psychiatric basis for their fear, then you can require them to come back to work under threat of losing their job. Consider whether or not somebody has a disability. So let's go now to the next slide, which is the employee permitted to stay home to deal with a sick relative or a minor child. Okay, this is the question that's going to come up. Your employee is not sick themselves, but they have a sick relative or a minor child at home. They don't want to come back to work. Well, first of all, you are not required to allow an employee to stay home. An employee cannot stay home without penalty to care for a sick relative or minor child under the ADA or state disability discrimination laws. These laws do not impose an obligation on an employer to allow this. You may be required to give the employee unpaid FMLA leave for this, depending on the circumstance. It meets the FMLA requirements, and you have a sufficient number of employees to be covered by FMLA. You may have to provide benefits under federal paid sick leave or extended family and medical leave if you've chosen to do them, and your local state paid benefits laws may apply. You have to check that out, but you're not required under the ADA or state disability discrimination law for an employee to stay home. Next question. What do you do when an employee, when you learn about an employee has COVID-19 as exposed? Send them home. Follow CDC guidelines about letting them return to work. And make sure you enter it into the OSHA log that you're supposed to maintain. And follow all reporting requirements imposed by the health department. Another question you're going to be asked is, you presumably have put many of your employees on furlough during this period. You're going to now start letting them come back to ramp up your ASC. A significant question that you're going to have is, what employees that you let return to furlough? They going to return to furlough. What can you do? And the answer is you can do a phased reopening. You don't have to bring all your employees back at once. You don't have to do all of that strategy. Whatever you choose to do, you have to do it from a legitimate business perspective. There has to be a legitimate business reason why you're preferring one employee over the other, because of job function, skill set, or whatever. It has to be a legitimate, non-discriminatory reason. What I don't want to have happen, and what would be terrible to happen, is if, excuse me, I'm going to sneeze, is if a practice or an ASC gets into trouble for an allegation from an employee and says, well, wait a minute, you took another employee first and allowed them to return to discriminatory reason. But if you're going to do a phase return to work, you need to make sure that you have a legitimate, non-discriminatory reason for why you're doing what you're doing. Okay? You could also change the employee's hours and schedule as long as it doesn't violate any employment contract. And you can also consider limiting vacation, PTO, and other benefits depending on what your policies are. Next question is, hey, what's going to happen when you start returning employees to work? There's going to be a lot more opportunities for overtime. That's just going to be a simple fact of life. There's going to be a lot of demand at some point, and you're going to have to deal with overtime. So let's go quickly over the overtime rules. I'm going to do New York separately and then New Jersey. With regard to New York, you must pay overtime at 1.5 times the standard rate of pay when an hourly employee works more than 40 hours a week. Now, if your employee is salaried, it's not an hourly employee, and falls within the executive, administrative, or professional exemptions, right? If they're an executive, administrative, or professional employee, you don't need to pay overtime. But it's very important to realize that New York has restrictions regarding this. For example, if a salaried employee is an executive or administrative employee, according to the exempt from the overtime laws, they have to earn at least $1,175 a week and $975 a week in National Suffolk and Westchester, or $825 a week elsewhere in the state. And for example, if you have a nurse who were paid hourly, and you want to claim the professional exemptions for them, that nurse must earn at least $684 a week. Okay. Now there are New York State statutes. There's the labor law, section 167, that restricts the ability to compel nurses to work overtime. You can't. That statute is suspended in the pandemic. And next page, I have the New Jersey, Connecticut rules. They're very similar. You can look at them in your own. And finally, let me talk real few seconds about COVID-19 liability exposure. If you're concerned about liability for exposing patients and employees to COVID-19, again, what we're recommending is that you.
Roy, it's Andrew. You're going to have to move a little closer to the mic. We're having a lot of trouble hearing you.
I'm sorry. You have to, if you're concerned about liability COVID-19 exposure, liability risk COVID-19 exposure, it's important for you to follow the CDC guidelines as much as possible. Remember, you could be held liable for COVID-19 exposure claims in workers' comp if an employee comes back to work and gets exposed in the workplace, or in regular old-fashioned tort liability if a patient or a visitor or an employee's family member gets exposed to COVID as a result of an exposure at your place. So the most important thing you can do is follow CDC guidelines as closely as possible, which gives you a very good defense to any type of liability claims. And with that, I'm going to turn it over to Dr. Brooks, who's going to talk about testing.
All right, great. Thank you very much. Thanks for having me and Nick here to tell you about some advances in testing and more importantly, what you can come to expect for testing services. So, you know, we appreciate that this is a difficult situation, and the last thing that you want to do with respect to employees and patients and opening up is to add insult to injury and provide a test that makes them more uncomfortable, potentially more uncertain, and may require additional retesting or other activities. So we've been working with the team on working out how we can deploy our testing strategy, which in the lab is very similar to what's being done with nasopharyngeal or oropharyngeal swabs, but a much better patient experience with a more robust testing scenario. So we offer and provide both swab and saliva-based testing. The swab-based testing is, I think, what you all are familiar with. It allows you to go into the deep, dark places that the virus loves to live. It's dark, it's warm, it's mucousy. However, for any given patient and how they present, or any healthcare worker, you're limited to what you can sample on the end of that swab. For saliva collection, you have a larger mass of sample, up to 2 mL of saliva, which is a much easier sample to take. The kits that are provided are in blister packs. You open them up, you spit into the funnel up until the black line, you pop the funnel off, you screw the cap back onto the tube, and it releases a blue preservation agent into the tube, which then stabilizes the sample and inactivates the virus. So it creates both a safe sample to be sent, as well as a very robust sample for collection. The process, whether you're using universal transfer media or viral transfer media from taking a swab sample versus a saliva sample, is the same once it gets to the lab. We extract viral RNA in an automated and high throughput manner using a bead-based nucleic acid extraction chemistry. We then miniaturize that sample, if you will, into a plate that runs 384 PCR reactions. And we use a chemistry by Thermo Fisher that's looking for 3 viral transcripts in order to be able to make a presumptive diagnosis, with the data returned inside of 48 hours, or between 24 and 48 hours from the time of collection. We tested this extensively, and we've got tens of thousands of samples, obviously, that have been tested, but the study that we provided to the FDA, which got us an emergency use authorization, or the very first one, was a study that compared nasopharyngeal swabs to saliva in this collection device. So we had independent verified clinical status on symptomatic patients. We collected them from a variety of ambulatory care facilities, and we compared that nasopharyngeal swab and universal transfer media to the saliva that was collected, as I just described, which is in that preservation agent that comes within the kit. And what we found was 100% concordance between nasopharyngeal swab diagnosis and saliva diagnosis. We now have expanded that study up to about 1,000 participants, where we have NPs as well as saliva. And what we're finding is there's about a 96% concordance across symptomatic and asymptomatic patients. And that 4% discordance in 1.7% of the time, 1.3% of the time is where we detect in NP, but not in saliva. But in 2.7% of the time, we detect in saliva and not NP. All of those cases are at the borderline of the level of detection. The sensitivity of the assay is at about 200 copies per ml, and that is really at the borderline with respect to shedding virus to be concerned about a transmission. Now, with that said, we don't see any real clear clinical correlates between symptoms and viral load, nor do we see any timelines that are consistent with respect to quarantine for employees that might show a positive. So a combination of a sensitive test like this, along with repeat testing, is going to be critical in keeping your facilities healthy, keeping your employees healthy, but also limiting the time of them being out. We've seen people on ventilators that have less viral load than those that are complaining of a loss of sense of smell. We have patients with persistent infection where they're shedding virus for up to 40 days. And then we have patients where after 3 days, they're no longer shedding virus. So the 2-week quarantine, if something can be tested, and again, with repeat testing, the ability to clear employees and patients faster while they're going through their own infectious journey can be important in your workflow and in your business. On this slide, you can see the collection is very simple. Again, you spit into the device. When you spit up to that line, you screw on the cap, you shake it for 5 seconds, you wipe it down with an alcohol swab, and you set it out for ADL to pick up the sample, or it can be FedEx back. About a week and a half ago, we received another FDA authorization for home collection. So what does that mean? It's not a test that's developed at home. It's not a self-test. It allows us via home collection to either provide a telehealth component, or having you send to your employees a kit, or having us send them a kit so they can collect at home, whether they're symptomatic, physically can't get to where they need to be, just for more convenience, quite honestly. It comes with a prepaid FedEx return or UPS return that comes directly to the lab and then is tested. So there are a bunch of modalities that can be used if you don't want people that are symptomatic or are known to be infectious in the office. There is an approach to get them kits at home, and the same thing for patients and clearing patients, to be able to get them a kit in order to get the results prior to confirming their schedule or having them show up at the surgical center. So hopefully that provides sorry, I have another slide here. So I'm going to pass this over to Nick Melchiori, who's going to talk about coding and reporting. And again, just before I pass it to Nick, for those of you that are looking for some resources, we can provide them for your employees, or certainly for your patients. But keep in mind, the test we're talking about is looking for RNA. So this is the measurement of active infection. This is what you want to know before you have someone come in for a procedure. And this is something you need to know before you have any of your staff in front of patients. The antibody test, which we also offer, and we're working on a number of other rapid tests. In fact, an antibody test from saliva, effectively from that same sample, but still under development, lets you know if you've been exposed to the virus and or have developed some kind of an immune response. Again, in that 1,000-patient healthy worker study, we're only seeing about a 50% correlation to what we would see for a normal immune response, where you feel you're sick, you get tested, we detect virus. A week later or 2 weeks later, you're no longer shedding virus. And then 10 to 15 days later, you produce antibodies that you can detect in your blood. We don't know what you're immune to. We don't know for certain you can't get infected again. We don't know how long that immunity lasts, but it is an indication you've exposed to the virus. But the business end of the test that we're looking at here, which is important, I think, for all of you to accomplish your goals, is whether or not you're actively infected. So I will turn it over to Nick for the coding and the reporting from Accurate Diagnostics. And certainly, once you get these slides, would be happy to answer any additional questions you have about the testing modality, sensitivity, specificity, any of the things that you feel you need to educate your patients or your staff with. Thank you.
Thank you, Dr. Brooks. This is Nick Melchiori. I'm the General Manager of Accurate Diagnostic Labs.
going to actually go back one slide. I've received a lot of questions in regards to the 96 hours versus 72 hours. From our approach and from speaking with our friends at Quest and LabCorp, we're all managing turnaround time to a 48-hour expectation the best we can. In New York State and New Jersey, I'm not sure about Connecticut, we're going to look at the date of collection. And one of the things you need to be really cognizant of is this is a point in time. So if I take the test on Thursday and it gets to the lab on Friday, turnaround time from your laboratory is typically going to be posted from the time it gets to the laboratory. So pay close attention to when the test is accessioned versus when the test is collected. So you're going to want to take documentation of when the test is collected, which would be in this case in my little graphic on Thursday, the 21st. Then you're going to get the result on Sunday, the 24th. It's not detected. You're going to need that result on that day of the 24th, and it really can't go over, right? So be cognizant of when the test is collected versus when it's accessioned. And New York State, Wadsworth, is going to be very keen on looking at that because they do life of a specimen. So does New Jersey, right? So a very key piece to take a look at. We know that our friends over at Quest and LabCorp are using nasopharyngeal swabs, throat swabs. So is Accurate Diagnostic Labs and our UCDR. We all accept nasopharyngeal swabs and oropharyngeal swabs. Accurate and RUCDR are the only FDA cleared assay for saliva. So that's a differentiator, but the testing is widely available by Quest, by LabCorp, by Accurate Diagnostic Labs. The testing is covered. So the key is when ordering testing, no laboratory at all has FDA clearance for asymptomatic patients. There's not a single FDA cleared assay for asymptomatic patients. So you're going to need to do an assessment for that patient before you order the test. I've heard some conflicting information about this. You just want to be cognizant that you're doing an assessment of the patient, not just ordering a test, and then providing an order from an ordering provider, right? So we hear a lot of information about other providers and drive-ups and things that you can do. Use your best guidance for what you're doing for this case. We've had some other questions about, can a patient take an at-home test? As long as you have a copy of that lab result and you have a copy and documentation of when the order was placed and collected, again, going back to that date of collection, and you have a copy of the result in your chart, yes, at-home collection. So Quest offers an at-home collection, LabCorp offers an at-home collection, Accurate Diagnostic Labs offers, and RUCDR offers an at-home collection. So there's several options there. The stability of our collection device and the ease of collection makes it easier, but there are multiple options out there. Dr. Brooks touched on antibody versus RNA already, and I think he did a great job. And there's basically three screening codes. Z11.59, that would be someone who's asymptomatic. Z03818, that's someone who had exposure but is ruled out after evaluation. And Z20.828, that's contacted with someone and has exposure. And I'll stop there because it's been a long presentation and I'm sure everybody has some questions, and I'll turn it back over to Andrew. Thank you, Andrew, and the team for allowing us to be part of this presentation, and good luck, everybody, with reopening.
Thanks so much. Okay, so we have a lot of questions, and we have 3 minutes. So here's what we're going to do. We'll take another minute. So let's assume we have a couple more minutes. But you're going to get the slides. It's going to have everyone's contact information so you can reach it. the people who, if you have HR questions, you reach Roy, testing question, you reach Nick. Okay, so one of the questions that we keep getting is, do I need a special consent to deal with COVID? There are some people who think not. We think yes, definitely, because this is an unusual time, and it'll be very hard to trace where somebody, God forbid, got infected. But one of the claims will be they got it at the ASC, and so you want to say, well, you understood the risks because we gave you the consent. Okay, Monica, let's stay with patients. If a patient calls up and they're feeling a little bit, I don't know, I don't want to risk it, I'm a little nervous, can you just kind of go through what would be your approach to make them feel comfortable?
I would talk to them about the screening that we are doing pre-operatively for all patients and for every single person that's coming into the center. So we're taking every precaution to make sure that there is no one with active symptoms in the center at the time that they would be there. We also have heavy-duty cleaning protocols going on. We are treating everyone as if they're positive, so everybody's really protected, even though they're not positive. So we're doing everything that we can to prevent exposure to them. By limiting the number of patients that we have, we keep them at distance from others. We have curtains. We have pediatric patients that we're actually putting shower curtains on the inside of our cloth curtains so that we protect them from kids coughing or crying or whatever on the curtains. And I would tell them if they really, really have concerns, perhaps they want to talk to their physician about it. But we would be quite consoling in the fact that we've done everything within reasonableness to protect them from others at the center.
Okay, Teresa, as you were a little ahead of the game in terms of opening centers, can you share some things that you learned that you wouldn't have thought of going into it?
Yeah, absolutely. So we have had different parts of the country that haven't had the same level of COVID, right? So they reopened a couple of weeks before us. So a couple of the lessons learned. So toggling the rooms. So we are recommending, because of the air exchange rates, that if you need, say, a 20-minute downtime, that use 2 rooms, right? So one team uses 2 rooms. We're finding that's what we're recommending, but we're finding some of the teams are actually saying that's kind of exhausting. And after a couple of weeks, they're resorting back to the 1 room. Some other things, make sure you do a break-even analysis of how many cases you do need to perform that day to make sure you're not losing money on a daily basis. That's a pretty important topic. Room temperature is another one. So the PPE can get pretty warm. So cool the room is an important topic. Redesign the waiting area like we discussed. Your break room, right? You want to make sure that you allow for social distancing, and you might have to schedule some different times for people to go on break. And the last one I did mention in the presentation, but I want to reinforce it again, that it's really important to have a PPE monitor, especially during the first couple of weeks, because this is all new. And many people, many nurses and endo especially, have not worn an N95 before. So I highly recommend that. So I'll end there. I know
excellent. Okay, so this is good. And by the way, guys, if you want us to do other follow-ups, send us. We'll do what the will of the people say. Roy, somebody asked a good question. I just paid somebody for 6 weeks of sitting at home and watching Netflix, okay? Can I say to them, well, that was your vacation, or that was your PTO?
So you have to be careful. While there's no obligation in New York and in the surrounding states to provide vacation, and there's a very limited obligation to provide PTO, once that becomes vested, to take it away raises issues regarding labor law violations. So depending on how the wording of your policy is, you're probably not going to be able to retroactively take it away if it's already been vested. And whether or not the leave has been vested is really how your policy is worded. Perhaps the best thing you can do is prospectively make a change to your PTO and vacation policy, or apply certainly for vacation. Most policies that are written say the timing of vacation is at the discretion of the business. You can limit people taking vacation, or as I said, amend the policy for the future. But vested,
Okay.
anyway, vested may cause problems.
All right. Okay. So we are out of time. On behalf of Garfunkel Wild and all the panelists, I want to thank everyone. Ask us questions. We'll try to respond to the list. And be safe and sane. And thank you very much for joining with us this afternoon.